My name is Imad Salman, consultant primary medicine at Health Point. It's a pleasure to introduce Professor Barbara Mcgowan, consultant endocrinologist at Guy's and St. Thomas Hospital, and professor of endocrinology at King's College London. She began her journey with a degree in biochemistry from Oxford University, followed by medical training at the Royal Free Hospital in London. She was awarded a PhD from Imperial College London for investigating the mechanics of appetite control. She's interested in management of severe and complex obesity, and she's interested in that field of pharmacotherapy for obesity. We're fortunate to have her here to share her insight and expertise. Thank you very much.
Thank you. Good morning, everybody, and thank you again for inviting me here today. Thank you, Sarah. Thank you to Dr. Haladad. Thank you so much. It's always wonderful to be here. I'm going to talk to you today about an update on medication. I think you've probably heard quite a lot already, so let's see if there's anything new that I can tell you today. So what I'm going to do before I sort of look at the present, I'm going to quickly look back at the past, and then we're going to talk about the current pharmacotherapies. But really the most important thing, we're really going to look beyond weight loss. Again, what can we achieve beyond weight loss for our patients? I'm then going to talk a little bit about what's coming in the future, in the pipeline, and then talk a little bit about safety, supply, the challenges that we have in terms of actually getting the medications to our patients, and some conclusions and takeaway messages. So you've all seen the slides a million times now. I think we all know that to achieve sort of remission of type 2 diabetes or reduction in cardiovascular risk or reduction in mortality, we really need to try and get sort of 15% weight loss and beyond. And it's fair to say that up until now, we've only really had bariatric surgery that has got us there. But hopefully, I can show you that we've bridged that gap. But let's look at the sort of pipeline of obesity drugs and what the history has been. And we all know that the history has not been a pretty one, okay? So most medications up until a few years ago have actually all been taken off the market, usually due to side effects. So we can go back as far as the 1940s and 50s and 60s with all the amphetamine-based drugs, fenfluramine, and all discontinued because of horrible effects to the heart, pulmonary fibrosis, cardiac death. More recently with sibutramine, discontinued in 2011, due again to increased cardiovascular risk. Then we've had rimonabant, which was discontinued in 2009 because of increased suicidal thoughts and depression. Lorcaserin in 2020 from the States, because of increased cancer risk. So really, we've not really been very fortunate. But now we do have drugs which are commercially available and fingers crossed, safe. So like I said, hopefully I'm going to show you that the bridge has been the gap has been bridged even with new meds. And of course, everybody has been sort of queuing up really to get hold of these medications, which it's been a challenge because the world is, I don't know, at least probably a third of the world is living with obesity. And why is that? Why have they all been queuing up and gone away from lifestyle? Sorry, charade. No, lifestyle is very important, of course. It's because they're effective and, like I said, fingers crossed, safe. So these are, just to remind you, the results of the STEP 5 semaglutide trial, which obviously started with the seminal trial of STEP 1, but essentially showing us that with semaglutide 2.4 milligrams, up to 2 years, we can get an average weight loss of 15%, which is maintained at 2 years. And this was the first time, I think, that we saw a double-digit weight loss with medication. And this was soon followed, of course, by tirzepatide. We've seen all the figures, all the results. But now, not only do we get double-digit, we're now into the 20% weight loss category. So we can see 22.5% with the 15 milligrams of tirzepatide. This is in patients without diabetes. Okay, so if we look at the categorical weight loss with medications that we have now, as you can see, over 20%, 25%, about a third of patients can get 25%. Again, we're now reaching that sort of bariatric surgical territory. What about loss of fat mass and lean body mass? We all worry about this because we are getting significant weight loss. And what we've seen from the trial, this is just a post hoc analysis from the SURMOUNT-1 trial. And what we can see here is that on the left there, you've got the percentage change fat mass loss in the blue in the tirzepatide arm compared to the change in lean mass on this side here. And you can see it's about 3 to 1. And what's been shown here are the 3 different age categories. So less than 50-year-olds, in the middle 50 to 65, and then over 65s, because we worry about the over 65s. And actually, it's pretty much the same. So overall, there is an sort of improvement in body composition with a 3 to 1 loss of fat mass to lean mass. Now, the other one thing that's really, really important is that we're treating a chronic disease. So when we stop the medication, this is the results of the step 1 trial, the weight goes back up to the baseline. And we can see that we're about roughly minus 5% from baseline after a year. Okay, so it's really important to actually educate patients that, this is a lifelong chronic condition which requires treatment. And the same was seen with the SURMOUNT-4 trial, where everybody started off on tirzepatide, and then at 36 weeks, half stopped and went on to placebo, and the other half continued on tirzepatide. And those on placebo started to regain weight back to baseline. And I showed you the results of this yesterday. Okay, but let's go beyond weight loss, because weight loss is really not what we're after. Weight loss is just a means to an end. And really, the benefit of these medications in other outcomes, health outcomes. And again, we're all familiar with the results of the SELECT trial. Okay, these are patients who had an MI or a stroke without type 2 diabetes, randomized to either semaglutide 2.4 or placebo. And very soon you can see divergence of this line showing cardiovascular benefit with a 20% risk reduction of further cardiovascular event or cardiovascular death. So very impressive. What about heart failure? Again, we've seen really good results on heart failure. So if you actually look, the bottom line shows you the weight loss with semaglutide. The top line shows you improvement in physical function as measured by this questionnaire, the Kansas City Cardiomyopathy Questionnaire summary score. So the higher the score, the better the physical function. So we have seen this in patients with a preserved ejection fraction. Very good, the cardiologists like this. And yesterday, we had a very nice lecture about the effects on the kidney. So again, patients with kidney disease, this was in type 2 diabetes, I should say, on 1 milligram of semaglutide, again showing improvements in terms of a 24% reduction in risk of kidney disease progression and kidney and cardiovascular death. And here you can see the reduction in eGFR, which on the semaglutide arm is much slower compared to placebo. Okay. What about OSA? Again, really good results from the SURMOUNT-OSA trial. This is using tirzepatide in patients with established OSA. Half the group were on CPAP, the other half were not on CPAP. But anyway, the results were very similar, and we saw some really significant reduction in the apnea-hypopnea index with the tirzepatide arm, as you can see. So this is the change in weight here, and significant improvements with quite a lot of people coming off their CPAP machines. Okay, so this is all good stuff. This is why we want to use medication. And I think more recently, very recently indeed, we've seen the results of semaglutide 2.4 in patients with osteoarthritis, and they used this WOMAC pain score to see whether there were any improvements, and again, a significant improvement in pain score in patients with osteoarthritis. So this is all good stuff. What about the future? Can we do better? Well, I think there's no doubt that the pipeline is an exciting one, and most of it is based on these nutrient-stimulated hormone therapies or gut hormone therapies or incretin therapies, however you'd like to define them. So we're all obviously very familiar with the hormone GLP-1 and now also GIP, the coagonist combination. But there are other targets, glucagon from the pancreas, amylin from the pancreas, PYY. So lots of combination of these targets which improve a number of metabolic parameters. There's also another category of drugs, which I will touch upon today, called the myostatin activin pathway inhibitors. And these are important because they've actually been seen to improve lean mass whilst actually leading to reduction in fat mass. And it may well be that in the future, we may be combining these agents with the current incretin therapies. So this is a snapshot put together by my lovely clinical fellow who was working with me in London, just to give you a little bit of a flavor of some of the medications. This is definitely not exhaustive, but we really are looking at combination of these gut hormones, so GLP-1, GIP, amylin with GLP-1, GIP glucagon and GLP-1 receptor agonists. We're looking at oral therapies, which hopefully will be able to increase access to the millions and millions of people across the world that will need these medications. And also monthly agonists, as you can see, in the form of AMG 133. So I'm going to show you just a few results, really, just to give you a bit of a flavor of what's coming, starting first of all with the oral agents. And the first one I want to mention is orforglipron. Now, this is a non-peptide GLP-1 receptor agonist. Why is that important, non-peptide? Because it's much easier to scale up compared to the production of the current peptides that we have. And what we've seen here in the phase 2 clinical trials is an average weight loss of around 15% on the maximum dose. So we look forward to the results of the phase 3 clinical trial. This was done in patients without diabetes. Now, more recently, we've also seen, I don't know if anybody attended the ASD, we had results from amycretin, which is an oral amylin and semaglutide co-agonist. And this was just the results, just 12 weeks. But here you go, in terms of weight loss at 12 weeks, roughly, as you can see, sort of 13%. Okay, so quite exciting. Now, at the moment, I think we're coming up to the end of the phase 3 clinical trials for the combination of this injectable, so semaglutide and cagrilintide. Cagrilintide is an amylin analog. And these were the original results of the phase 1 clinical trials, which showed that at 20 weeks, we're getting 17%. So we look forward to see whether this was reproduced in the phase 3 clinical trials. So this will also be quite a potent combination therapy with amylin, cagrilintide, and sema 2.4. Right. Now, we also have exciting results, I think, from the triple hormone therapy, also called retatrutide, for those who can pronounce it. And these were the results of the phase 2 clinical trial. So you can see here that on the highest dose, the mean weight loss was now nearly 25%. Okay, so, and not only that, if we look at the categorical weight loss, about just over a quarter of patients lost 30%. Okay, so these are potent medications, okay? Now, the good news, I think, is that if you are a woman, you lose even more. There was quite a difference between women and men, so I thought I would show this, that actually women lost about 28%, and I think versus about just under 22% for men. So I don't know whether there is something about the estrogen in the water that makes women lose more weight, but we'll wait to see what the science will tell us going forward. Now, moving on, these myostatin activin pathway inhibitors. So essentially, on the left there, what you can see is that if you activate myostatin and activin A, these are pathways activated usually during, we see these pathways activated in cancer patients. They lead to cachexia and muscle loss, okay? So if we actually inhibit these pathways, I guess people ask the question, can we improve? Can we reverse that process? And indeed, these treatments are trying to do exactly that. They're trying to disrupt the activin receptor signaling pathways, leading to increase in muscle cell protein synthesis and preservation of muscle function. Now, one of these agents is called bimagrumab, and these are the results of the phase 2 clinical trials with bimagrumab, which was an injection, I think, every 4 weeks versus placebo up to 48 weeks. And the results of this phase 2 clinical trials showed roughly 20% fat mass loss with a 3.6% increase in lean muscle mass. So some exciting results. And I think there are also clinical trials going on in combination with, so this plus I think with semaglutide, I think. So we look forward to seeing those results. This is just some of the pipeline. Again, looking at these agents. So I think the point I'm trying to make is that the future is quite rich. There's a lot going on in this space as well, and we look forward to seeing some of the results in the future. Okay, what about safety? Like I said, the history of these drugs has not been a good one. Do we have a better safety profile? Well, I think touch wood, at this point in time, things are looking okay. We're all familiar, of course, with the side effects, the gastrointestinal side effects of GLP-1. In this particular sort of database, looking back at many, many million of patients on various medications, what the data showed that if we compare GLP-1 agonists, I think they compared them to sort of bupropion and naltrexone, there was definitely a 9-fold increase in pancreatitis. And of course, we know that patients that lose weight quickly are subject to gallstones, which can lead to pancreatitis. There was a 4-fold increase in bowel obstruction and 3-and-a-bit-fold increase in gastroparesis. So we need to be aware of these effects with the GLP-1s, and we need to inform patients. What about cancer? There's lots to talk about cancer. Even yesterday I was asked a question about thyroid cancer. And I mean, there's lots of evidence that I could show you. I just thought I'll sort of highlight this systematic and review and meta-analysis looking at 13 study of 46,000 patients, essentially showing that there was no evidence for increase of pancreatic cancer, there was no evidence for increase in thyroid cancer, and indeed there was no evidence of increase of any cancer. And of course, I'd just like to remind you that, as you know, obesity is associated with an overall increase of cancer, so if we can actually get the weight off, that risk reduces. What about suicide? There was a lovely lecture yesterday about suicide, psychiatric effects and so on and so forth. And again, I could show you lots of papers, but essentially there's no risk of increased suicide at this point in time from the evidence. This is just something that we've just published looking at the post-hoc data from all the STEP trials, which again did not show an increase in symptoms of depression or suicidal ideation or increased suicidal risk. I should say, of course, that one of the limitations with these trials is that patients with severe mental illness were excluded from the trials, okay? But of course, we do know that a lot of patients living with obesity have a high burden of mental health or psychological illness. Okay, what about the challenges that we're all facing in terms of supply, demand, cost, and various inequalities? Okay, this is just to remind you that we've had a huge surge in demand. This is data from the USA, and I think the demand for GLP-1 agonists has gone up by about 2,000%, I think, since the launch of semaglutide 2.4. And I think 1 in 8 Americans, they've all had a go, haven't they, Ryan? They're all on it, Donna. And what else? And of course, this has meant a huge shortage of these medications. I think we've all been subject to shortages worldwide. Certainly, we had this in the UK, and patients with type 2 diabetes could not get hold of the medication because everybody was using it for weight loss. But there has been some recovery in the UK in terms of supply. But let me tell you what's happening on the ground, and I'll give you the UK example. That's where I practice, just to sort of give you a little bit of perspective. So we know that the licensing for these medications, and I'm talking about semaglutide, tirzepatide, is for patients with a BMI of 30, or 27 plus 1 complication of obesity. Now, of course, millions and millions of patients meet these criteria just in the UK. Now, what does NICE say? NICE is the National Institute of Clinical Excellence, which in the UK tells us that at least for semaglutide, which is the only NICE approved, like I said, we are waiting for tirzepatide, they're telling us we can only give it to those with a BMI of 35 plus 1 complication, and indeed only for 2 years, which is completely crazy, of course, because why would you stop medication for a chronic disease? But anyway, let's put that aside. So that's what NICE said, and there's about 4 million people in the UK that meet just these criteria. What is actually happening in the hospital at ground level? Well, we've got 4 million people, but we have no funding for this. So who are we prioritizing? So we've had to come up with our own criteria, actually. We did this with the Society for Endocrinology and the Obesity Management Collaborative, which I chair, to try and give some direction as to who we can prioritize. So who are we prioritizing? Well, we're prioritizing those, for example, with an active malignancy that need to lose weight to be eligible for surgery or radiotherapy. We're prioritizing patients who need an organ transplant, a kidney transplant, or a heart transplant. Those with idiopathic intracranial hypertension with recurrent headaches requiring lumbar punctures. Those with time-sensitive surgery for, hip replacement or a knee replacement, for example. Or those, for example, that need IVF and need to lose weight quite quickly because it's time sensitive, perhaps are approaching sort of, the ages of 40 and beyond. And finally, with those with severe sleep apnea and obesity hyperventilation syndrome. So this is who we're prioritizing. And if I tell you that within the NHS and National Service, we've prescribed about to 700 patients, but there's been about 400,000 prescriptions in the UK. So most patients are getting these medications privately because we're failing them in the NHS. Okay, so we've got a challenge. And the issue is this: we've got a highly prevalent disease with huge patient suffering and social costs. We all know this. And we've got these very effective medications, but of course they're expensive. And of course, most patients suffering with obesity can't afford them and don't have access to them. So I think, we do have a challenge, and it's up to us to try and meet that challenge. Before I finish, I just wanted to mention something about the digital weight management and how we can support patients, because like they're currently on the ground, we just don't have the services to do it. And I think it's fair enough. I think we've all learned quite a lot about digital services during the COVID pandemic. We know, for example, they can help in terms of increased reach, especially those patients that live far away. There's reduced time and environmental impact because people don't have to travel to appointments. There's also the potential to expand services very rapidly because we don't need physical space, and we can tailor the support to individuals. And now, in the UK, there are several weight management digital interventions which have been approved by NICE. I'm involved with one of them called Roxanne, and these are the results of our lifestyle interventions that we've delivered digitally to patients, sort of showing roughly about sort of 8% weight loss, but we can also cater now for the medication. And I think it is important to offer patients, a multidisciplinary approach, and, the usual wraparound care that we would offer, in a face-to-face service. And it's also fair to say that currently there's a lot of online prescribing where there's very little governance and very little patient support. And I think we have to be mindful because these medications, like I said, are powerful. They can, lead to significant weight loss, and we need to be able to ensure that patients are safe and they have adequate nutritional support. So, in conclusions, the take-home messages are that, first of all, I think current medical therapies have bridged the gap between lifestyle and bariatric surgery. And I think the new dual and triple hormone therapies are showing really good, promising results in terms of pipeline. But I do think that we have inequalities of obesity care, lack of access, lack of funding, which I think will continue for several years. And hopefully, when we introduce oral, more cost-affordable medication, we may be able to meet some of this challenge. But I think, it's, like I said, we need to think about this and how collectively we're going to sort of help the situation. And with that, I'd like to thank the team at home. Thank you very much for listening. I'm very happy to take any questions.
Thank you. Thank you very much, Professor Mcgowan, for this wonderful talk. Questions?
Yes. So thank you for sharing with us the interesting new data. So we know that with the incretin therapies that are coming up and that are more potent, we have a concern for muscle loss. So do you think with these new agents there is much more need for lifestyle interventions, meaning specific goals in terms of protein intake and muscle training?
Yeah, so really important question. So I talk about pharmacotherapy, but of course, the pillar of all of this intervention is lifestyle, nutritional, and physical activity will play a very, very important role because, like I said, we are losing over 20% with these new medications, and it's really important to preserve muscle, lean mass. So physical activity, very, very important. High protein diet, really, really important to ensure that, because these medications are very powerful, they will switch off appetite. People will come to you and say, I don't feel hungry anymore. So it's really important that high protein is prioritized. Because if not, patients will come back, they'll feel tired, they'll start to lose their hair, so absolutely important. I think the role of the dietitian will change somewhat in that the medication will do the calorie restriction, but it's really important that adequate nutrition is supported. Yes, hi.
Yeah.
Yeah, great presentation. I have a question about the flow study that you mentioned, the benefit of, the GLP-1. Did they control for the other medication used, like SGLT2 inhibitors?
Sorry, I'm not sure.
The flow study. which showed beneficial effect on the kidneys.
The effect on the kidneys? On the flow study? Yes, sorry, yes. That's a good question. I can't remember can anybody help me with answering that question with the flow trial, with the control? I'd have to look that up. That's a really good question.
Thank you.
I'm sure it hopefully was controlled for the SGLT2s as well. You're absolutely right, but I can't remember the details offhand.
Thank you.
Yes, they're saying yes, it was. Okay, thank you, team. That's a very good question, yes.
Great talk, Barbara. Basically, Asians are the big ethnic minority in the UK, so would you consider lower cutoff figures for diagnosing these obese patients rather than the 30 and 30 for obesity or 27 for overweight?
So, excellent question. How do we define obesity, actually? So there's no doubt that we need to, take into account different ethnicities and correct by about 2.5, as you know, so in terms of the indications for the medication. But I think you raise an even bigger question, and I think lots of people have spoken about this, and I think even Rachel yesterday, and indeed the ASO has new guidelines for defining obesity, looking at not just BMI, but also waist to height ratio. So even a BMI of 25 with a waist to height ratio of over 0.5 is defined as obesity. And I think future clinical trials should look at this rather than taking people in and just defining them with just using BMI, basically. But so I think we do have to be pragmatic. But of course, funders may limit how you are, if you have to stick, to what the rigid guidelines are. But in practice, if we can, absolutely. I think anybody with a BMI of 25 plus a waist to height ratio of over 0.5 is probably eligible for these medications.
And very short question regarding the retinopathy and GLP agonists. Would you warn patients of these? There's a lot of talk about like retinopathy and side effects, or with the GLP. Would you tell patients, or would you be considering like these are one of the side effects or complications?
Do I tell patients about side effects?
Regarding the retinopathy.
Retinopathy. So I think if patients have got type 2 diabetes and they have retinopathy, and especially if they're on insulin, if they've got very poorly controlled HbA1c, it doesn't matter what the intervention is, we have to be careful because very rapid reductions in glucose, which these agents would lead to, can worsen retinopathy. But we see this with very low-calorie diets. We'll see this with bariatric surgery and, of course, with these agents. So I think we need to, it's not a contraindication, but I think we need to be careful on how we use these agents, and we need to use them sort of slowly and titrate up, maybe perhaps do retinopathy screening as well. So it's a...
Sorry, because of time, we don't have time for more questions. And I'm sure Professor Mcgowan will be happy to answer your question during coffee break.
Thank you.
Thank you very much.